Most of you know the optimal guideline directed medical therapy. Today my focus will be on the challenges while prescribing the ARNI in heart failure with reduced ejection fraction. This talk is supported by Novartis. As you know, the mortality of the heart failure with reduced ejection fraction is highly significant, and it competes with some of the cancers with 6 months mortality, 1 year mortality almost 32%, depending on the severity of the heart failure. And all of us know the 4 pillars of the heart failure, that is the beta blockers, MRA, mineralocorticoid receptor antagonists, ACE inhibitors or angiotensin pathway inhibitors, including ARB and ARNI, and SGLT2 inhibitors. So, from the Kerala registry, we know that most of the Indian patients are being treated suboptimally for the heart failure with reduced ejection fraction. And in the registry, it has been clearly shown that when the guideline directed medical therapy is implemented, the mortality is significantly low. Now, the guideline directed medical therapy is endorsed both by ACC and ESC, and it lowers the current GDMT can be initiated during hospitalization for heart failure, and or can be started and soon after the hospitalization, or in patients who are not hospitalized. And latest trials show that rapid escalation gives even better results. Now, ARNI, angiotensin receptor neprilysin inhibitor, in chronic symptomatic HFrEF class 2 or class 3 patients who are not tolerant of ACE inhibitors or ARBs, ARNI can be given. And ARNI also is recommended in patients with de novo treatment in hospitalized patients with acute heart failure before discharge. Now, what is the evidence backing ARNI? Most of us remember the paradigm heart failure study, which was published I think more than 12 years before. It has shown highly significant reduction in primary composite endpoint that included cardiovascular death as well as the heart failure hospitalization, highly significant. One point that has to be remembered, in the paradigm heart failure study, the sacubitril valsartan was started at a dose of 50 milligrams and escalated to 200 milligrams. And enalapril, most of the patients received 20 milligrams. Most of us in our practice, especially in India, we don't give so much high dose. Most of us nowadays are not giving enalapril, we moved on to ramipril. But even this, we don't give high dose. That point I just want to highlight. Now, in the patients with HFrEF, over a period of 28 weeks, the dose can be escalated from 50, 100 to 100. The latest strong heart failure study published I think last week has clearly shown there is significant incremental benefit if you can uptitrate these medicines faster over 2 months period. Now, even while you are giving ARNI, the concomitant use of beta blockers, MRA, all the 4 drugs we give, and fortunately SGLT2 inhibitors and MRA, you don't have to escalate the dose. The dose of spironolactone or eplerenone in the classical studies was only 25 milligrams, and SGLT2 inhibitors, dapagliflozin is 10 milligrams, you don't have to escalate them, whereas beta blockers and ARNI have to be escalated, and this can be done concomitantly and comfortably over years. And despite of so much evidence, the use of ARNI in India is very low, very decimal in the National Heart Failure Registry, 3.6 or 4%. It is not that our physicians do not know the importance of ARNI or not knowledgeable. It is because of the fears and concerns. The fear is some patients may not tolerate medication on recommended doses or may have side effects or fearing complications. That is the main concerns. So, in an analysis, when we see why the guideline directed medical therapy is not given as per the recommended dose, the concerns included as per the ARNI, the concerns were hypotension, hyperkalemia, or just physician inertia, or renal impairment. These are the three aspects which I am going to highlight. Why is it the knowledgeable physicians or cardiologists are not giving ARNI, are not initiating, or not escalating? These are the three main concerns. Now coming to hypotension. Patients with heart failure with reduced ejection fraction, heart failure with reduced ejection fraction has to be seen basically as a threat to maintain the blood pressure. When the heart failure occurs, when the systolic dysfunction dysfunction occurs, the cardiac output is decreased, and to maintain the blood pressure, the vascular resistance increases, systemic vascular resistance, that's what maintains the blood pressure. So, when you decrease the systemic vascular resistance, there is a fear that the blood pressure will fall. But if you allow it, the heart failure will worsen because the afterload increases. Now, when you give ROS inhibitors, they decrease the systemic vascular resistance and can actually lower the blood pressure. So, the main limiting factor in the treatment of heart failure is not hypotension, but the lack of understanding the concept of hypotension. Now, what is the optimal blood pressure? How much blood pressure does anybody require? Optimal blood pressure required is the circulatory pressure, perfusion pressure should be sufficient for the person to stand erect and go around to doing his activities. So that much blood pressure, if he can, is sufficient. If it is 90 millimeters or 100 millimeters, doesn't matter. As long as the person can stand erect and go on doing his activities, that much blood pressure is optimal, and it's not necessary that person has to achieve 120 by 80 millimeters of mercury. So when a person is started on ARNI or AC inhibitors, when the blood pressure lowers, the first reaction is to take away the ARNI. But that is not a correct approach. If there are no signs of congestion, discontinue or decrease the diuretic dose first. If that's not, if you have to give that optimal dose, see if there is any other medicine like isosorbide hydrogen or calcium channel blockers or similar drugs which are causing the hypotension, and first you decrease them before decreasing the sacubital valsartan. And even in patients who have achieved lower systolic blood pressure, the sacubital valsartan combination is beneficial in decreasing the mortality and hospitalization. And hypotension that occurs with ACE inhibitors is actually much more problematic. Risk of death is higher than hypotension caused by ARNI. So one can safely use ARNI even when you have got borderline hypertensions. Other problem is hyperkalemia. With growing number of CKD patients, heart failure patients taking ROS inhibitors and MRAs have hyperkalemia. Actually, at one point of time we are seeing more of hypokalemia in heart failure patients. Now we see more of hyperkalemia. Compared to ACE inhibitors, ARNI has lower incidence of hyperkalemia. And also, when you combine with mineralocorticoid receptor antagonists, the hyperkalemia is not so severe. So one is more comfortable, one have more leverage while giving ARNI when suspecting hyperkalemia. Then third problem is the renal failure. The cause of worsening renal failure during decompensation episodes needs careful thought, because heart failure and renal failure go together. One common misconception is the renal failure is often due to decreased cardiac output. While that is true, the most important determinant of the azotemia or worsening renal failure is the increased central venous pressure. So nearly 1/3 of the patients with heart failure who have got azotemia, you decrease the central venous pressure by enough diuretics, the renal failure improves. Now, what I mean to say, there are different causes of renal failure. If you go through the cardinal syndrome type 1 to 5, we see the heart failure renal failure combination is not one entity, it's different entities. And while prescribing or not prescribing ARNI, one has to take these things into consideration. So what is the impact of sacubital valsartan on renal function? The lower incidence of elevated serum creatinine with sacubital valsartan versus ACE inhibitors in chronic HFrEF patients. This you can see patients with HFrEF on ACE inhibitors have higher chance of worsening renal failure compared to when they are taking ARNI. And also, the discontinuation of treatment due to renal dysfunction is more often seen with enalapril than with sacubitril valsartan. And also, the sacubitril valsartan improves or maintains GFR in real world HFrEF patients with CKD compared to ACE inhibitors. So, in patients with HFrEF and CKD, sacubitril valsartan scores over ACE inhibitors in preserving the renal function or preventing worsening of the renal function. In patients with renal dysfunction, when the GFR is more than 60, there is no need for dose adjustment. With moderate GFR reduction between 59 to 30, also again there is no need for dose adjustment. In severe heart failure, severe GFR reduction less than 30, one can start with 50 milligrams and then gradually increase monitoring the serum creatinine levels. So in conclusion, lack of GDMT was associated with higher risk of mortality in Indian heart failure patients. ARNI is recommended as first line therapy for all HFrEF patients, but use of ARNI is very low in India. Sacubitril valsartan has good overall safety profile, significantly lower risk of death despite a hypotensive event. Serum potassium levels was persistently lower with sacubitril valsartan as compared to enalapril, and significantly lower reports of serum creatinine more than 2.5 milligram per deciliter with sacubitril valsartan as compared to enalapril. Thank you.